Hello, good evening, everyone. Welcome to another session of Zooming Through ID with Dr. Gopal. Um, I am I'm Dr. Gopal, infectious disease specialist, trained at Duke University, been practicing here in South Florida for over 20 years. I'm a teaching faculty for internal medicine as well as infectious disease. I'm an APD for the ID fellowship program here at Broward. I also chair the stewardship for the Fort Broward Hospital, and I'm the chair for infection control at Broward Health North. Zooming through ID is a focused um, teaching forum where the residents and fellows they take ownership of their learning. We we assign them a topic or they select a topic of their interest, and then they research through that topic, and this is where they showcase what they have learned and they will be teaching. And today we have Carlos. He rounded with me and he did ID elective rotation, and we were talking about a topic, and he has picked a very interesting topic, and he was wonderful. He had great bedside manners, and he had an enthusiasm to learn, and it was a pleasure working with him. And he is going to teach us all about Helicobacter, and it's a very cute topic, an interesting topic, and it's going to be a great presentation. So, Carlos, I'll let you introduce yourself.
Well, hello, everybody. Name's Carlos Andres Jaramillo. I'm a first-year resident over at Broward Health North down in Deerfield Beach, Fort Lauderdale area. Nearing the end of my first year, learning plenty, especially in the infectious disease area of medicine with Dr. Gopal. Not too much to know about me since I most of my time spent in the hospital, but I try to have some fun outside of the hospital here and there. But went ahead and chose a topic like Helicobacter because it's something that we often test for with the amount of people that have acid reflux complaints. And they're a good chunk of the time negative. But when it does come back positive, I'd love for people to be more aware on what the current treatment guidelines are, because I know I was taught one thing and board exams would test you in a certain way, but I'd rather people know what's accurate for the current guidelines. So I can go ahead and start my little presentation. Let's see right here. Okay. Can we see the presentation?
Yes, yeah, it's perfect.
Perfect.
Okay.
All right. So here's my presentation on Helicobacter pylori diagnosis and treatment. So first, to start off, in the clinical setting, unless you're going into like pathology labs, unlikely you're going to be seeing any Helicobacter pylori yourself. But just for background, what it appears on under a microscope, they're flagellated helical and gram-negative species of bacteria. When it comes to the more epidemiology and the risks for this condition or any sort of sequelae, H. pylori is a major cause of disease linked to chronic gastritis, which you spoke a little bit on with our little intro, can lead to that constant inflammation can lead to peptic ulcer disease. And the scary thing is, with all that chronic inflammation damage, is eventual risk for gastric cancer. Infection is usually acquired in childhood, but also spreads well within families. It puts you at a higher risk if you do have somebody positive in your family and have that close association with them. And then that obviously, because it increases in general your risk for peptic ulcer disease and gastric cancer, it'll subsequently increase your familial risk for those two different sequelae. When it comes to gastric cancer, it is a major burden on the healthcare system globally. It is the sixth most common cancer and third leading cause of cancer death worldwide. Um, it's one that can also be fairly easily avoided via treatment of the condition. H. pylori infection. Uh, oh, There we go. Okay. So when it comes to H. pylori infection, it is on the decline as we test for it more often. We're treating it properly. Improvements in the sanitation and food preservation and preparation, and just access to more like good sources of food that aren't as contaminated, which with bacteria like that. So the actual H. pylori, I remember back in med school, one of the things they taught us was that one of the scientists that discovered it theorized that it would cause this peptic ulcer disease. And the exciting part of that story is that to prove it, he went ahead and ingested some H. pylori to show that it does cause some of that chronic damage, and it did lead to him having some peptic ulcers. But as I said, it is something that we can avoid with the proper treatment of this organism. So when it comes to actually treating the H. pylori, there's current consensus is that there's no proven benefit to avoid treating it. It's not just gastritis. It's not just like a lifelong thing they'll have to deal with. It is something we can treat here in the now and prevent so many horrible complications down the line. When it comes to diagnosis, if we're in the realm of med school, they'll teach you about some of the tests, the very common one, the H. pylori breath test. But there's a few different tests, both invasive and non-invasive. Invasive, unless we have some other reason to be doing the invasive ones, unlikely we'd be doing those. It's more common to be doing the non-invasive tests like the urea breath test, stool antigen, or even just serologies. When it comes to more invasive ones, that's kind of like endoscopic testing, which could include like cultures or biopsies. But very, very much we're using the non-invasive tests, and they have a good rate of catching these diseases. When it comes to some of these testings, you have to be aware of the drawbacks of choosing one over the other. Something like the non-invasive, the urea breath test or the stool antigen, there is some issues with if you're going to be using these tests, you do have to stop patients from taking their proton pump inhibitors, their antibiotics, their bismuth, anything that could be affecting the test for 2 weeks, which of course the patients aren't going to be too happy to have to remove these medications that are helping them with their symptoms. But for a proper test, we have to hold off on them. The serological testing for certain antibodies towards the actual bacteria, it is pretty available, but the only problem is it doesn't really tell you whether it's an active or a past infection, just that there was an infection at some point, whether it's right now or not. So it's not as often as the urea breath test, which shows like an active infection. It's actively transforming the urea, and that can be detected with the test. So now when it comes to which patients to test, they're divided in how much evidence there is behind the actual criteria on testing. Very good evidence is showing that if you have a suspicion for H. pylori infection due to they have an active duodenal ulcer, or they have a history of gastric or duodenal ulcers, if they have as like this acid reflux and it's not been investigated in any way, and even with immigrants, if you're coming to us from U.S. immigrants, if they come from a high prevalence area of infection, there's very high evidence to be testing these individuals, especially if they have any of these concerning symptoms. Then we get to like lesser evidence, still enough to warrant it here and there. It's just if they have any sort of MALT, some lymphomas, can point towards that there was some sort of risk factor that they had, or they reside, like we were saying, it was a risk factor to be family with somebody who has an active infection. that could there's a moderate evidence towards testing these individuals as well, or even just having a family history of the disease. You're around the family. It just puts you at a higher risk. And so there's a decent amount of evidence pointing towards testing these individuals out and just at least ruling it out. And then when it comes to the lowest amount of evidence, it's not really what you're going to base it off of actually testing, but it's something to put out there, is that it's just based on racial and ethnic groups. Like I said, immigrants, if they're coming from a certain area that has high prevalence of this disease, sure. But just based on racial or ethnic groups is not there's no evidence behind it. You need the risk factors, being family, being having any of the like sequelae of this infection, or even just having the active reflux issue. And then we have the actual sequelae, just to show you a little bit of an example. The peptic ulcer disease that is caused by that constant chronic damage from these organisms, common locations being the stomach and then the duodenum. So the gastric ulcers and then the duodenal ulcers, just a little image so you can see when they do endoscopic checks on these patients, what it might look like. So to hit on one of those sequelae when it comes to the H. pylori, the gastric cancer, the one that we're most worried about, it's typical what you're kind of taught when it comes to cancer beyond just the incorrect repair of DNA. It's the chronic active infection, inflammation, constant damage to these cells in these areas, which can lead to worse and worse replacements of those cells, leading to metaplasia, and that can lead into any sort of the constant damage leading into DNA structural damage that can eventually become something like a carcinoma. So it's the big driving factor being that inflammation that the H. pylori causes just from chronic disease. The gastric cancer itself, it risk for it depends on how fast we're progressing through the gastritis, the different degrees of it, the extremes of it. If we're progressing quickly to actual ulcerations, that burden on the body does put you at a little bit of higher risk of it. And even geography can affect the actual percentage risk of developing this gastric cancer, whether that is because of just the higher risk because you're in certain areas of the globe versus some other underlying reason. Not entirely sure at this point, but there is some correlation there. And when it comes to gastric cancer, treating this H. pylori infection radically reduces the risk for this gastric cancer in the long run. So there's no reason not to treat these patients and avoid any sort of more severe disease. Now, here's where we get to the treatments. With H. pylori, I know I was taught a certain way when it comes to treating because it's what was going to be on the board exams. Now, nowadays, these bugs are getting more and more resistant to our different antibiotics, whether it be maladherence, just not enough antibiotic stewardship, what have you. But there's a rising resistance to the medications we were often using for these infections, such as clarithromycin, metronidazole, and even fluoroquinolones. So the treatments such as, I know I was taught about the triple versus quadruple therapy. The triple, really obsolete. We should not be putting patients on the triple therapy of the PPI, amoxicillin, clarithromycin, the metronidazole versus the fluoroquinolone. The triple therapy is no longer really being used. You're under treating the patients because it's just they have such a higher odds of being resistant to some of these medications that you're just going to lead to either further antibiotic resistance, not actually eradicating that population of that organism. It's too risky. So treatment itself, The cure rates definitely could be better, and I think with the current guidelines, they can improve. It's just that there's that rising antibiotic resistance, so making the cure rates a little bit more difficult to achieve the higher cure rates. So currently, as I was saying, the triple therapy, you can't really use it unless you have just antibiotic sensitivities to point towards these specific bugs and this specific patient are susceptible to these medications. Otherwise it's just not worth risking it. And when it comes to the treatment itself, it tends to be a treatment of at least 2 weeks, and you need to be testing the patient afterwards to make sure that they did have a cure of this condition. Because of these rising resistances, we need to confirm that there's no longer an active population of that organism affecting this patient. And when it comes to retesting them, it's going to be a test of cure is going to be 4 more weeks after the therapy has been completed. So the options currently being used today, kind of a little summarization of it, is the quadruple therapy that you might have been taught in medical school about, the bismuth. These are the specific regimens on screen. So the bismuth itself, 2 tablets. So 30 minutes before meals, a tetracycline of some kind, metronidazole, and you're going to go ahead and also have that PPI on board. So that is our quadruple therapy. That's the one that I was taught in medical school. And that's the go-to right now. Another option, a good option, is a different type of triple therapy, one that uses a medication, rifabutin. That one, rifabutin plus amoxicillin plus the PPI, has been shown to be effective as well, along with the quadruple therapy. So then it might be just a matter of sensitivities versus price versus access for these patients. So it's just going to depend on your judgment there. So when it comes to the proton pump inhibitors, specifically, we want to use the higher potency ones in these patients. We don't really use something like pantoprazole. The conversion of that to esomeprazole is just not strong enough and doesn't have a good enough data to point towards us using some of the weaker PPIs, and we should be sticking to more of something like esomeprazole or rabeprazole. So now post-treatment testing. So as I was saying, really need to be testing these patients afterwards to make sure that the antibiotic did clear the infection and to prevent any more rising resistances in our treatment regimens, because it'll just get more and more difficult to treat these patients and avoid our scary sequelae. Usually urea breath tests or stool antigen tests, like I was saying, 4 weeks after completion of therapy, should be able to tell us whether they still have an active infection. And then further testing we can also, if there's any sort of issues, we can check these specific pathogens for what resistances they do have, so we have a better idea in the future for any population around us what antibiotics work best for them. So in summation, H. pylori, definitely a significant source globally for just peptic ulcer disease, and the scary one being gastric cancer. So it's very undertreated because of the just past guidelines that have been used, and with the growing antibiotic resistance, it's a bug that we need to be aware of, and one that we need to be treating properly so we can avoid just the extra burden on our population and the medical burden on them for any sort of sequelae they might be dealing with. And the current recommendations are the quadruple therapy and specifically the triple therapy of the rifabutin. The old triple therapy is no longer used unless you have sensitivities that prove that they are susceptible to that old regimen. And then to make sure that these patients are tested afterwards for clearance of the infection. So part of our just stewardship and just treating the patient properly, making sure that we take care of every aspect of this disease and avoid any further harm to the patients. Now, also included in this little presentation, I wanted to include some board questions for some of those people that might see a question or two on their specific boards. So I'll just go through these quickly for you. Here's an example. So a 72-year-old woman is evaluated at a follow-up appointment. 8 weeks ago, she was hospitalized for melena and near syncope. Upper endoscopy performed during hospitalization showed a duodenal ulcer with no visible vessel, dark blood in the stomach, and no active bleeding. Results of a rapid urea test of biopsy samples from the antrum and body of the stomach were negative for Helicobacter pylori. She was discharged with a prescription for omeprazole, which was discontinued 2 weeks ago. She's currently asymptomatic. She has osteoarthritis and before hospital admission had been taking naproxen, which has since been discontinued. Physical examination findings, including vital signs, are normal. Which of the following is the most appropriate next step in management? And I hope you have your choice. Yeah, so we have A, B, C, or D. Order Helicobacter pylori serology. Perform a urea breath test for Helicobacter pylori. Repeat upper endoscopy or no further management. And the answer to this question is B. Perform urea breath test for the Helicobacter pylori. Management of this patient should be done with the urea breath test. With the evidence of an upper GI bleed, the actual invasive testing that we spoke about earlier with endoscopy, there's decreased sensitivity for the bug itself. So just because it was negative does not prove that there is no active H. pylori infection. And so these patients should be further tested and to avoid any sort of undertreatment of this population. Another question for you. A 60-year-old man is evaluated for several months of epigastric discomfort and nausea. He has not lost any weight and does not have early satiety or symptoms of gastrointestinal bleeding. He has COPD and benign prostatic hypertrophy. Medications include a tiotropium inhaler and tamsulosin. On physical examination, vital signs and other findings are normal. Laboratory study results are normal. Endoscopy shows a non-bleeding gastric ulcer. Biopsy of the ulcer reveals marginal zone lymphoma, like we spoke about earlier, and results of H. pylori testing are positive. CT scan of the abdomen and pelvis show no abnormalities. Which of the following is the most appropriate treatment? I guess I cut off the A, B, C, or D, but A, H. pylori eradication therapy, B, gastrectomy, C, radiation therapy, D, rituximab, and E, rituximab plus cyclophosphamide, doxorubicin, vincristine, and prednisone. So the proper treatment for this patient would be the H. pylori eradication therapy. So for this specific question, the presence of that gastric malt lymphoma with a positive H. pylori test has a low chance of transformation to a more aggressive lymphoma. And very often with proper treatment of that underlying H. pylori infection, it can prevent that transformation in that early lymphoma to something more aggressive. And so another thing that just goes to show, actually properly treating these patients for H. pylori infection can just avoid so many devastating just diseases on these patients. And there's my references for my presentation, and I hope you learned
Okay.
something.
Yeah, it was great job. I think you covered pretty much everything, and it was wonderful. Couple of add-on points. The the It's a gram negative, like you mentioned, gram negative, and then it is catalase positive, urease positive, and oxidase positive. So they may give a case scenario and say this is the bacteria, and you will identify as H. pylori. Then there may be a next question: what is the mode of transmission? And they will give you a few choices like perinatal transmission, eating raw vegetables, and then um, And then there may be a choice, person-to-person transmission. So H. pylori is transmitted person to person through secretions, and there is no congenital transmission, and the only host is humans for the H. pylori. So that's some additional. And the great point, the other take home, like you mentioned, never do serology. So the urea breath test and biopsy and stool antigen test are the testing, and the treatment, the quadruple therapy, the bismuth included quadruple therapy that is for treatment. And it's, overall, I mean, the resistance patterns, as you touched, and that is also an increasing problem. So excellent presentation. Good job. Thank you, everyone, for joining.
Much.